Satish sir, start, please.
Good evening, all. This is my pleasure to start with the meeting, which is one of the, I would say, very important uh, topic of tips of office pediatrics. Sir has made Dr. Bhavesh Mithya, Dr. Ram Gopal, Dr. Amol Pawar. He has designed in such a way that each and every pediatrician of the corner of this Maharashtra, as well as even abroad, even national level, they're enjoying these tips, and these tips are becoming more and more useful for the daily our practice. And such a tip of like tips of what we require in our daily practice, even of the immunization or in vaccination, because backbone of pediatric practice is also immunization along with other infectious diseases. And if you are very expert in that or very good in that, you definitely have that extra advantage in your own practice. And to, I would say, carry forward this wonderful webinar, which has been designed by Dr. Bhavesh Mithya, Dr. Angopal, and Dr. Amulpa, who none other can moderate this. So we have this wonderful faculty, and I welcome on behalf of Maharashtra IIP to all of you, our faculties, delegates, Dr. Nitin Shah, our mentor, and many more. Dr. Manjusha is there. She is from the Women Committees. We see day by day increasing number of our attendees. So I request Dr. Ram Gopal sir to start with the session, say a few words.
Thank you, Dr. Satish. Good evening, everyone, and welcome you all on the platform of Tips in Office Pediatric Practice. As the name itself suggests, we are going to get tips. I think today I should have labeled it Tips from Kulkarnis. We have Dr. Ganesh Kulkarni and Dr. Sharmila Kulkarni. So we should have modified the name. So welcome Dr. Ganesh Kulkarni and Sharmila Madam. And see, we are fortunate to have Dr. Nitin Shah sir along with us. So we will be benefited by his experience. So sir, whenever required, you can give your valuable inputs. And our moderator, Dr. Sanjeev, I think he has already prepared a lot of questions for Dr. Ganesh Kulkarni and Kulkarni Madam. I will not take much time. Over to you, Satish. You can start the session.
Yeah, I request our dear Maharashtra IIP Secretary, Dr. Amol Pawar, to say a few words.
Thank you, Satish sir. It has been a very hit session, and this is actually a fourth session of this year, and it is very well designed by Dr. Bhavesh Mithya sir, and coordinated by Dr. Sanjeev Joshi sir, who is moderator today. I welcome on behalf of Maharashtra IIP. I again welcome to all delegates, faculties, President of President, Dr. Nitin Shah sir, then all Executive Board members, Jitu sir, and Maharashtra IIP Executive Board members, office bearers of various branches across Maharashtra, and all PG students also. So I would like to thank Dr. Nitin Shah sir for joining, and he will also be guiding us in this session. And I request Nitin Shah sir to have some words of wisdom from him. Nitin sir, please.
Thank you, Amol. I'm very happy to be here. And today is a session which is very near to my heart. So I always say that I'm a hemato-oncologist by profession, by vaccinology, by passion. So today is the topic of my passion. And I'm very happy the two budding vaccinologists, Ganesh and Sharmila, who are very good and very close friend of mine, are the panelists. There is none other than Dr. Sanjeev Joshi moderating. I'll be very happy to learn from all of you some tips on vaccinology today. Thank you.
Thank you,
sir. So it is this moderate this Jugarbandi of vaccinology. I think there is a wonderful person sitting here, Dr. Sanjeev Joshi. Like he has got such a good experience. I think at the age advances, he's getting more and more young, and age is just number for me. So he's a director of Critical Care and Joshi Children Hospital, Yavatmal. Just not take much time because everybody knows, sir. I just want to take him as a charge of this session and start the session, sir.
Thank you, Dr. Satish, for those very kind words. Respected President of Maharashtra IIP, Ram Gopal, our dynamic secretary and mitochondria, Dr. Amol, today's guest of honor. We are really blessed to have Dr. Nitin Shah, sir. And the two main stars of today, Dr. Ganesh and Dr. Sharmila, the vaccine man and a versatile academician lady. We are really blessed to have such a wonderful speakers, those who are going to enlighten our august audience on this virtual platform. Welcome all the office bearer of Maharashtra IP, Jitu, other CIP members, and all the office bearers of the branches. And without wasting much time, we will start. I'll start sharing. And
मी स्टॉप करू शेअर सर.
तू stop कर. Yes. I'll start sharing my screen, and I know at the end of this session, all our august audience will be back full of take-home messages. As Satish has already told, that vaccination is the backbone of our office practice. Rather, I would say that it is a bread and butter. पण आता काही दिवसापासून बटर गेलेली आहे, फक्त ब्रेड राहिलेलं आहे. तर बघू आता आपण ब्रेडला किती डिलिशियस करू शकतो. अँड व्हॉट बेस्ट vaccination practice we can advise, or we can, how much queries of day-to-day vaccination issues we can address. So we all know, friends, vaccine protects not only the individual but the community. And vaccine not only protects the individual and the community, but also helps to eradicate, to eliminate, and to certain extent control the disease. And to guide us for this next 40-minute session, we are really blessed with a versatile, all-rounder lady from Nashik, none other than Dr. Sharmila. She has got a very spectacular academic and professional career, a lot of achievements and awards to her credit. At the national level, she has won so many prizes. She is the past president of Nashik IAP, and she has a good social connect also, and with a good international experience also. So, and the other one, गणेश, हा फोटो कॉलेजचा आहे की पोस्ट ग्रॅज्युएट डेचा आहे, अंडर ग्रॅज्युएटचा आहे की पोस्ट ग्रॅज्युएट डेचा आहे?
That's the only one that probably became good.
So
That's
the
what I
vaccine
feel.
man from Maharashtra, Ganesh Kulkarni.
He has stopped aging.
Yeah, he is alumni of Wadia Children's Hospital. Then he was organizing chairperson of NNC PID, organizing secretary of Mahapedicon. He had lot of good. He had an honor of doing some clinical practice, clinical studies in the field of vaccinology. So thank you, Ganesh, for accepting our invite. Thank you, Sharmila, as well.
Thank you so much.
So we will just start our ball rolling, and the first question goes to the lady. The lady has to be honored first. So, Dr. Sharmila, we will start with, see, we have shortlisted 4 to 5 vaccines. And these 4 to 5 vaccines are most commonly used in our day-to-day practice now. Since for the first 6 months, we don't have much opportunity now because of our robust NIP program. Most of our patients goes to NIP program. But after 6 months, when they comes to us, that is the opportunity which every pediatrician in the office practice should encash and should enlighten them, or should elaborate them the advantages of the vaccine which are to be taken after the age of the 6 months. So the first and the foremost vaccine which we are going to discuss is a rabies vaccine. And we know that India is one of the hub for the world cases of rabies. Maximum number of cases of rabies comes from India. So the first and foremost practical question to Dr. Sharmila is how you categorize the wound, Dr. Sharmila, because that is very primary issue when you think about starting uh, rabies vaccination to any particular child with a so-called animal bite. So, Dr. Sharmila, how do you categorize the wound?
So thank you so much, Dr. Joshi. I also thank MahaIP for giving me this opportunity. And I would say that the only constant thing in the world is change. And there are a lot of changes that we see in vaccination because it is a dynamic science. And that's why this recurrent sessions are very important. So let's talk about how to categorize the wound. Now, why is it important? Because the management and the prognosis both will change according to the category. Now, let's take an example. If a child is on the road and a dog or any animal comes and licks the child's leg, the mother hardly notices it. But this comes under the category 1. And therefore, friends, we should know this category. So even touching or feeding animals, lick on intact skin, and contact of intact skin with secretion, all this comes into category 1. Management is simple. We hardly have to do anything. But the important thing here is to see whether really the skin was intact. There's a simple test. You just do the spirit test. You apply a little spirit on that area. If there's no sting, this is an intact skin. If not, there's definitely, if it stings, it is a breach in the continuation of the skin, and then it goes to category 2. So in category 2, we get nibbling of the uncovered skin, minor scratches, and abrasion, but there is no blood. So with a breach in continuity of the skin and no blood, this is category 2. And the third category, of course, is single or multiple transdermal bites, scratches with bleeding. So there is a transdermal lesion plus bleeding. So that comes under category 3. And even contamination of the mucous membrane, the conjunctiva, the tongue, the mouth, all this comes under category 3. And then according to the category, the treatment will differ.
So, Sharmila got your point. So, the august audience must know that anything with broken skin and bleeding and multiple wounds are category 3 and 3 and 3 only. So, the first and foremost reaction or what action, what you will take, Dr. Sharmila, once you see the child with with an animal bite, and when you are planning to give anti-rabies vaccination, what will be the first and foremost step which you will take?
Okay, so if a child comes to me, the first thing I have to do is confirm the category and do wound management. So wound management will be same in all categories. Okay, the category 2 and category, and that plays a crucial role in management, because if we can do a very good wound management or good wound hygiene, that will decrease the risk of having rabies by about 50%. And therefore, wound management plays an important role. And how to do it is very simple. We have to know only 3 steps. The first step is to copiously wash the wound with water and soap. And not only just wash, we have to hold that part, the limb, under water for not 5 or not 6, but 10 to 15 minutes. So under running water, you just keep the part after washing it with soap. So that is the most important step. The second step, of course, is you use a virucidal cream. So you have to use any ointment which has 70% alcohol, or which has which you can use a povidone iodine also. So that is the second step. And the third important step here that we have to know is never ever suture a wound. There is only one exception, and that is if there is copious bleeding and we have to achieve a homeostasis, then we can suture on rare occasions. But we have to remember that anytime we think of suturing, we first have to infiltrate the wound with the monoclonal antibody or the immunoglobulin. So these are the three steps.
Very nice, Dr. Sharmila. And once you are done with these 3 steps, what Dr. Sharmila has elaborated, you almost got rid of 50% of the virus load. Now coming to the second question, I would request my esteemed panelist or the speaker to be crisp and precise so that we can address as many questions as possible. So we know that which animal bite needs post-exposure prophylaxis with anti-rabies vaccine. But what are those animals which bite, or which animal bite does not need post-exposure prophylaxis with rabies vaccine? Just
Okay.
1, 2, 3, 4.
So one is domestic small rodents. So they include the rat, the mice, hamsters, even squirrels, guinea pigs. All this come into domestic small rodents at home. The second thing is Indian bats, and the third thing is human bites. So these are the only three bites where we would not, on most occasions, give a vaccine, but there are many vaccine experts who differ. And I would not, because we have to be crisp, I would just say that these are the bites we will not give vaccine routinely.
So there are certain nowadays that NC has recommended certain intradermal regime, and your patient has come with first dose of intradermal, which has to be practiced in the government's setting only, since ACVIP and AIP has not recommended it in our office practice. So the first dose was taken as an intradermal dose. How I should give now second dose? The child has come to you on day 3, and how you proceed with the child?
So here I think there are three things we have to remember. First, that as you say, ACVIP recommends intramuscular dosing. That is first. The second thing, intradermal is, it is recommended that we should never change the route of administration. That is the second thing. It is acceptable but not recommended. And the third thing we have to know is that intramuscular and intradermal both have very good efficacy. So with these three things in mind, I would say that this child had received first intradermal. I would most probably like to continue giving intradermal to this child.
Okay. So, or you can change to the intramuscular also as
Yes.
per the ACVIP. Okay.
Yes.
Okay. Okay. So we got your point. Now we have a child who has received complete post-exposure prophylaxis 6 months ago. Now he presented to you with class 3 bite today. How do you proceed with this child?
Okay, so the first thing is he says, the parent says that they have received the post-exposure prophylaxis, but we have to have a documented proof. And if that proof really shows that the child has received all the necessary vaccines and whatever, even the immunoglobulins, then there are three things we will do. The first thing is wound hygiene. It is same. This is category 3 and we have to do it very sincerely. The second thing is the vaccination has been done. So now we will be doing a revaccination. So in revaccination, we are advised to give 2 doses only, one on 0 and one on the 3rd day IM. So that is a second step. And of course, because the child has been vaccinated before, there is absolutely no role here of giving any monoclonal antibodies or immunoglobulin.
Okay, very nice, very practical answer. Now, for another situation, for previous category 3 bite, child had received only 2 doses of ARV. And now after 2 years, child had again got category 3 bite. What will you do now? And would you ask, whenever you ask the previous vaccination history, Dr. Sharmila, you must also ask what was the site where the vaccination was given, whether it was arm, whether deltoid, or whether it was a gluteal region also.
Right.
So how do you deal with this situation? So, previous three bite child received only 2 doses of ARV. Now after 2 years, again had cat 3 bite.
Right. So this is an important point that you made, that we should always see that there's no injection given on the gluteal region, because a rabies vaccine will be invalid if it is given on the gluteal region. So always give the vaccine on the anterolateral aspect of the thigh or in the deltoid region. So that is a point well taken. Now, this is the child who has received 2 doses. So as I said, this is incomplete vaccination, and any incomplete vaccination is invalid. So here the vaccine is invalid. So now after 2 years, I will I will consider this child as a new patient and give him everything. We'll give the vaccine, we'll give him the monoclonal antibiotics and the wound hygiene.
Thank you so much. Thank
Can
you.
I can I
Your
interrupt?
point. Yes, sir.
So I would ask the history of these two previous doses given at what interval? If they were given as 0 and 7, then that's a valid pre-exposure prophylaxis. So anyone who has a valid pre-exposure or a valid post-exposure prophylaxis in the past, on re-exposure, anytime in life, just needs 2 more doses and no RIG. But if this child took 0 and 3 and then stopped, then that is not valid pre-exposure because the interval is shorter than 7 days.
0 and 7 as a pre-exposure is acceptable, but
Yes.
if the child has been bitten twice by a dog, I think the antibody response may be incomplete, and here then we are warranted in giving the monoclonal antibodies.
Suppose you have a child who has taken 2 doses at 0 and 7 as pre-exposure, where there's a pet at home. Now he comes after 2 years with a fresh bite. What will you do?
Which one, sir?
You will not
Class
give-
3 bite?
You want no, whichever class. Yes, pre-exposure. A valid pre-exposure means is same as valid post-exposure in the past. Now this is re-exposure, which means only 2 doses without RIG, unless the patient is immunocompromised, where he will need, of course, RIG also. So this child, if he had taken in the past, incomplete schedule, but the schedule was 0 and 7, that becomes a valid pre-exposure, even though it was started as a post-exposure. That is the point I made.
You consider the first bite as non-existent and consider the 2 injections which has taken as a pre-exposure prophylaxis.
Absolutely.
Right.
Yes. Yes. Now, I think I will twist this question, Dr. Sharmila. We all know the advantages between the monoclonal and the RIG. But when we talk about the monoclonal, we have 2 choices now. One is a cocktail, which is called as Twin Rab, and another is the Rabies Shield.
Yeah.
So, what will be your choice if at all both of the these monoclonals are available, and if at all you want to choose, if you are advocating in favor of Twin Rab, what are your thinking process about, or what will be your rationale for using Twin Rab?
So
Of course,
I
your
feel,
first choice will be Rabies Shield. I do agree about that. But
yeah,
if at all you are using Twin Rab, so what will be your rationale for using Twin Rab?
so
Or how do you compare these two? Like,
right. So both actually, the Rabies Shield is a recombinant human IG with a G1 protein, and it neutralizes about 25 different species. The benefit, if at all, ACVIP recommends both, and both are equal for us. But there is probably one point which may go in favor of Twin Rab, and that is it has 2 antibodies, and it, besides the rabies virus, it also neutralizes other rabies like viruses. So probably that is a small advantage of Twin Rab over Rabies Shield.
okay. But there is also a theoretical risk of sensitization since it is a murine. Okay.
Yeah.
So, but the take home should be whichever is available, you can use. Okay. Both are equally effective. Sir, anything you want to add, Shah sir?
Yeah, the cost consideration. I mean, the Twin
Okay.
Rab is 4 times more expensive than the Rabies Shield,
Okay.
not easily
Yes, sir.
available. It's
Okay.
a murine antibody, so post use once of this monoclonal, there is anti-monoclonal human antibody produced in almost 15 to 20% subjects. Suppose the
Yes.
child needs a re-exposure immunoglobulin because he becomes immunocompromised, there will be a problem because it may not work as well. So looking at everything, cost and this urine and the possibility of a cost, I mean the re-exposure need again in immunocompromised, my favor is always using Rabies Shield. Other thing is,
Yes.
Rabies Shield is now available in only 50 units. So,
Yes,
you need 3.3 units per kg. Average child is
Yes.
between 8 to 15 kilos. You
Yeah.
can save on money because you're using a smaller dose. So the cost will become even lesser than using 100 units.
Yes. Your point is well taken, sir. Now
And
coming
the
to our
last point on this is that remember the 3.3 units per kg of the Rabies Shield
Rabies Shield.
or 20 units per kg of twin wrap or 40 units per kg of twin wrap is the maximum dose. Doesn't mean you have to give that much dose. If there's a small wound which can tackle only with 0.1 or 0.2 ml, then don't have to inject everything there. And never inject the remaining dose intramuscularly, because that is a practice which is completely given.
Thank you, sir. Thank you. So now coming to Ganesh, one of the most effective but little bit complicated vaccine in the basket is pneumococcal vaccine. So what are the various pneumococcal vaccines which are available in India, and what is the future of PCV in our nation?
Yeah, because this looks like a whole lot of story here. This is a wonderful story of PCV vaccination, which hasn't really reached to its final destination as yet. The first vaccine that came into the market was PPSV23, which is a polysaccharide pneumococcal vaccine, which has the highest number of valency, like 23, and which is still top on the list. But it is a polysaccharide vaccine. And then there was almost a path-breaking invention of conjugate technology, and the conjugate vaccines started coming into the market. The first one which came was PCV7, which was immediately replaced by PCV13, which was on 2000. It was launched, and then after 10 years came the first PCV10 vaccine from GSK, and then subsequently it took almost 12 years to reach to a PCV10 from indigenous, like Indian giant Serum, getting it for us. And then now recently we have seen a new launch of PCV40 by Biological E, another Indian giant. So as of now, we have 4 conjugate vaccines which are available in the market. And then along with that, the PPSV23 polysaccharide vaccine is still available. Now, if you compare these two vaccines, like the PPSV23 has the 23 valency, the highest valency, that is what it is. But it is a polysaccharide vaccine, which is way inferior to what the conjugate technology is. Now, in case of conjugate vaccines, PCV13, which probably we always try to compare our other vaccines with PCV13, the vaccine from GSK, which is PCV10, does not have 3, 6A and 19A, which is there in the PCV13, whereas the vaccine PCV10, which has come from Serum, does not have 3, 4, and 18C as compared to the PCV13. And the new vaccine that has come recently into the market is that PCV14, which is from Biological E. It actually does not have 6A, but it has additionally has 22F and 33F. Now, this is where, we are still trying to find out which suits us in a better way. But having to tell you that the serotype, availability of serotypes into a vaccine does not mean more serotypes is better vaccine. Probably is not the true story. It is basically because the demographically, epidemiologically, which serotypes are prevalent in which area, that probably would not, it would be difficult to find out area-wise per se. So that is where, we need to find out probably which are the commonest serotypes that are prevailing in our Indian soil, and which is the vaccine that contains almost many of these serotypes, and that becomes a choice of probably a vaccine for us. So this is what. And then PPSV23 probably is still there in the market, despite having a very inferior kind of a technology as compared to PCV, the conjugate vaccines, just because it has the highest number of valency it is. So that in case of very particularly high-risk patients, we still want to give them a benefit of these additional serotypes. That is why this particular PPSV23 is still there in the market. So this is what. Now, coming to the future of PCV vaccines in India, if you say, probably not in India and globally also, there are a lot of newer PCV vaccines are there in the pipeline. PCV20 is almost launched in the European market, which is still there. It is in the western side of the world, which is there. Now we have MSD coming up with PCV15, which has 6A in it, and which has 22F and 33F. So it has added that 6A, which was not there in Biological E's PCV14. And then we have PCV20, almost it is also on the verge of getting launched in Indian soil itself. And it has additional, all of those 15 serotypes of MSD, and on top of it, it has 8, 10A, 11A, 12F, and the 22F. So they have additional 5 serotypes to it. So this is what, in fact, Government of India is also planning to come up with, along with that direct benefit to the transfer conditions, it coming up with one PCV15 vaccine, which has 2 and 12F in it. So this is overall lot of vaccines which are there right now, which are going to come into the market. The bottom line is what the maximum prevalent serotypes are there in our soil, and the vaccine that contains all those serotypes which are prevailing in this particular soil should be chosen. That is my take on it.
So, from here, the most important takeaway is the seroepidemiology of pneumococcal infections is dynamic process. It is not a static
It is a dynamic
one. Yes, and you may have 14, you may have 15, you may have 20 also. But my direct question to Ganesh or even Nitin Shah sir can also answer, is adding more and more serotype is going to improve the immunogenicity of that vaccine, or it is just for the protection of that particular individual?
I'll give a try, and then I hope even Nitin Shah sir, I will need his help. I feel, see, immediately PPSU 23 was launched, it was 23 valent. Why so many serotypes were added at that particular time, 1983, but we still are struggling to add so many serotypes in conjugate technology? That is because conjugation is always with carrier proteins, and more number of serotypes you start adding more and more carrier proteins as well into the vaccine. And the more number of carrier proteins, this is something which is called as a bystander suppression. So these the carrier proteins which are added into a vast quantity tries to suppress the immunogenicity of other serotypes. So it is always a challenge.
Excellent.
To keep on adding serotypes into a vaccine. So that is the reason why I would say that adding more number of serotypes is not really a good thing. That is because simultaneously we need to see the immunogenicity of each and every serotype has to be preserved.
Thank you.
I request
Ganesh,
Nitin Shah sir to please comment on this, because
hello सर है क्या? हेलो सर नहीं है शायद. ठीक है, we'll ask him later on. Now after this, Ganesh, we have different schedule in NIP and in our
office practice,
ACVIP, IIP office practice schedule. So what the NIP practice is 2+1, 2 doses below 6 months and the booster at the 9 month. And our ACVIP is 3+1 booster, that is 4. So how do you compare these two? And what is the difference, whether this 2+1 is for the cost effectiveness, or it is also equally immunogenic as that of our 3+1?
Yeah. See, basically, WHO has approved 3 different schedules. That is, one is 3+0, that is 3 primary plus no booster. Second is 2P+1, that is 2 primary plus 1 booster. And the third is 3P+1, that is 3 primary plus 1 booster. Now, why WHO said, allowed these 3 different schedules? It is for the stakeholders and different countries to, form which particular schedule suits to their country, See, depending upon the local epidemiology of each and every country has its own stakeholder which will decide about which schedule the country has to follow. Now, if you consider 3P+0, this is a very good schedule, but only for those local epidemiological conditions where, the disease prevalence or disease burden is very high, below 32 weeks of, age. So that means if you have a very high burden in first 8 months of life, then probably 3P+0 becomes more effective. Now, 2P+1, this is something which is, our Indian government has adopted it for public sector. There are a lot of things like local epidemiology along with programmatic feasibility also has to be seen, because the cost of adding one more dose is definitely a considerable situation. But when you give 2P+1, is it really comparable to 3P+1, which is said to be a gold standard? Now, 2P+1, when we start giving with this particular schedule, it definitely has a comparable antibody titers as 3P+1. but not as good as that. It is a bit inferior to 3p+1 in terms of OPA titers. 3p+1 has a better OPA titers. Now, second problem with 2p+1 is when you give 2p+1, you probably have a lower immunogenicity for 6b and 23f, these two serotypes. So that also has to be taken into consideration. So that is the reason why Government of India has started 2p+1 based on local epidemiology and programmatic feasibility. Now, coming to the third one, which is 3p+1, which is scheduled for our office practice, and ACBI recommends it because lesser than 4 dosages, if you give 3 pneumococcal vaccines, probably it does not reach to that GMT titers, which works upon to reduce the nasopharyngeal carriage as well. And top of it, the OPA titers are much better when it is 3p+1. And that is the reason why when we want to give a kid a benefit in our office practice, we try to give it 3p+1.
So your take home for the audience is 3 plus
3p+1.
Okay?
That's the best possible schedule.
Thank you. Now you have a situation, Dr. Ganesh. You have an unvaccinated child, 2.5-year-old, needs PCV. Which brand, how many number of doses you will recommend for this particular child? He has not received any pneumococcal vaccine before.
Okay. So that means it is unvaccinated and 2.5 years old, right? So we know that for an unvaccinated 2.5 years old, first I will try to categorize it into whether this is an immunocompetent child or an immunocompromised or immunodeficient child. By saying that if it is a 2.5 years old unvaccinated immunocompetent child, that means I'm trying to give a catch-up vaccination here.
Okay.
Now, for a catch-up vaccination, I would give him 1 dose of PCV13 here, and this child would not need any kind of polysaccharide vaccine thereafter because it's not a high-risk condition. But having said that, if this is 2.5 years unvaccinated but immunodeficient child, which is a high-risk child, then I would give PCV13, 1 dose. Along with that, if it is unvaccinated, I would give him 2 dosages of PCV13, 8 weeks apart, and then I would give him 1 PPSV23 after 8 weeks, after the last dose of PCV13. And if it is very high risk, like congenital immunodeficiencies or hemoglobinopathies or splenic conditions, then I would give him another PPSV23 after 5 years of age.
Got your point. And below 2 years, you have to practice 3+1. That is for
3+1.
Sure. Okay.
Yes.
Okay.
Yeah.
Now I have a situation of unvaccinated child, 8.5-year-old. Does he need PCV if he is an immunocompetent?
If he is an immunocompetent, actually the recommendations do not say that he needs a PCV because the disease burden of invasive pneumococcal disease above 5 years is not as daunting as it is below 5 years. So recommendation wise, you are not supposed to give a PCV vaccine to this, but there are a few studies, Agarharkar study, which says that even after 5 years, this vaccine is very immunogenic and has a good efficacy to give it. But as far as recommendations are not there, we are not supposed to give him that vaccine. If he is immunodeficient, then again the same thing, PPSV and PPSV.
If it is a high risk category, then we will definitely follow
1 PPSV 23 after.
Yes. And now you have a very common situation, especially in my demographic area, a 6-year-old boy. He has recently diagnosed as a HBSS disease, and he has received only the NIP vaccine schedule. So he must have received 2+1 doses of PCV
2+1 schedule.
Okay. So how will you deal with this situation now?
Yeah.
You have a 6-year-old.
This is actually a very high risk case as far as immunocompetency is concerned, because this child has homozygous sickle cell disease, and that is the reason why at 6 years this child needs pneumococcal vaccine. Right now, this child is unvaccinated before, or no, this child has received 2p+1 this vaccine. Now, if he has received 2p+1, still I would give him 1 dose of PCV13 and followed by PPSV23 after 8 weeks and followed by PPSV23 second dose after 5 years. But if he has received full dose of 2p+1 in immunization schedule, that is fine. Then he has to receive one PCV13 because to give an advantage of additional serotypes.
So if at all I say that he has not received any pneumococcal vaccine, now how will be your approach?
Then I would be giving him 2 dosages of PCV13, 8 weeks apart. Okay. And then again, 8 weeks apart, I would give him PPSV23, and 5 years afterwards, PPSV23 again.
So the take home from Ganesh is that when you have a high risk situation like a sickle cell disease or a asplenia or other situation, then the choice is of 2 vaccines only. When you consider pneumococcal vaccination, the first one is the PCV13, and another is the PP23, the polysaccharide 23. And now the chronology has to be followed.
Yes.
As Ganesh has rightly said, you have to give first PCV13, and after 8 weeks of PCV13, you can give first dose of PP23. And if at all situation demand, second dose after 5 years. So this is the most rational schedule to have a good boost up of immunity against the pneumococcal serotypes.
If at all somebody has given by mistake, somebody has given PPSV23 as a first dose, then we wait for 8 weeks to give PCV13, and then we wait for 5 years to give PPSV23 again.
Okay. So if at all it is given prior to PCV13, that is an invalid dose in a high risk situation. Okay.
Yeah.
Okay. Thank you. Thank you. Thank you so much. Now, I think this question goes to Dr. Sharmila. We all know that cervical cancer is one of the highest common malignancies in the childbearing age in the women all over the world, and especially the contribution of the Asian countries is almost 90% to the caseload and almost that much to the mortality. If you talk about India, almost there are 77,000 deaths secondary to cervical cancer, and that too in the age group of 30 to 45 years, where that woman is active, where she could be a mother, she could be a professional, she could be she is one of the important pillar of the society and also that household. So if at all we have a vaccine which can prevent malignancy. Till now we were talking about prevention of communicable disease, but there is a communicable disease, a viral infection due to human papilloma virus, which is the sole etiology for one of the most commonest cancer of a childbearing women, and that is cervical cancer. So why not to prevent that? Why not to make our nation as a cervical cancer Mukt Bharat? So, Dr. Sharmila, what are the different HPV vaccines which are available nowadays, and what is the importance of the different serotypes which are responsible for the cervical cancer or the other related anogenital cancers? Because we have 150 serotypes of human papilloma virus, but there are 4 to 5 only which are very important, or up to maximum 9 to 13, say. So what are those important vaccines which are available, and what is the importance of serotypes? Dr. Sharmila.
Right. So as you so rightly said, this is the only prophylactic vaccine for cancer, cervical cancer in women. And I'll just like to add that in all these women, 99.7% have documented DNA, HPV DNA. And so it's definitely a very, very effective vaccine. So as you said, we have how many HPV vaccines? So the bivalent GSK vaccine is not available across the globe. So we have 3 vaccines with her. We have a good choice. We have a quadrivalent vaccine from Serum Institute. We have a quadrivalent vaccine from MSD, and then we have a nanovalent vaccine also from MSD. So we have these three vaccines, and there are more than 200 serotypes, out of which only 15 to 20 serotypes are oncogenic. And out of this 15-20, the 16 serotype is the most oncogenic of all. So therefore, all these vaccines have a 16 and serotype, and the 16 and the 18 serotypes, they account for nearly 70% of all the cervical cancer that we see, while
Almost
the 9-valent. Pardon?
Yes, yes. Almost 80%, 16 and 18.
Yes. Yeah. So, and the 9-valent, if you leave the 6 and 11, then 7 of the 9-valent, they account for more than 98%, they coverage. So this is the significance of both this vaccine. Then there's a 45 serotype, which is more common in North, while a 35, which is more common in South. So these are the different serotypes which are more common in different areas. Now, all these quadrivalent vaccines, they provide about 80% protection against the invasive cancer, while the nanovalent provides as much as 98% protection against. So that is the importance of the nanovalent vaccine over the quadrivalent vaccine. Now, I think you asked another question.
What is the schedule like? What is the schedule, and what is the importance of that age specific?
Right. So basically, let me first tell you about the.
So which schedule you should recommend, and what is the most effective?
Unmute yourself.
Unmute.
Yeah. So there, in a very simple way, how you can remember is, I'll just here name the vaccine to make it more simple. The Cervavac vaccine, which is from Serum Institute, the quadrivalent vaccine, that can be given, that has to be given between 9 and 26 for both girls and boys. So this is also a gender neutral vaccine,
Okay.
right? The second vaccine, the quadrivalent from MSD, that has two groups, 9 and 40. That has one group, 9 and 45, only for girls. So this is not a gender neutral vaccine. And the second vaccine from MSD, that has two groups. One is 9 to 26. Here you have to give it to only the boys, and 9 to 14, where you can give to boys and girls. So I think once we fix in, we can put this chart. This is a tip I would like to give, and because it can be confusing, just put this chart on your in your clinic so that you remember. Once you remember that, then the dosing becomes very simple. The dosing is between 9 and 14, there are two doses, 6 months apart, and from 15 years onward to 26 or later on in ladies, the dosing is 3 doses, and that has to be given 0 to 6. So these are the different dose schedule, and this is how it makes it easier to remember the vaccine schedule.
So the most effective protection by HPV vaccine is the age when as it is a prophylactic vaccine, it has to be given when the actual contact with the human papilloma virus occurs. So that is before the sexually active age group, and that is 9 to 14. So when in that particular age group, we have the best efficacy and best effectivity of this.
One thing I like to add here, if the child is immunocompromised, then whatever age you have to give 3 doses.
Okay, so 3 doses.
Right.
Now, there are certain literature which is emerging about a single dose of HPV. There was one Costa Rica study. So what is your take on this single dose HPV? Is it
okay?
Does ACVIP recommend now, or it is still under consideration?
Yeah. So in short, in a single word, if I have to answer that, it is no, the ACVIP does not recommend as of today a single dose. Probably down the line, it may start recommending. As you talked about the Costa Rica study or the trial, the Kenshi trial, all these trials, basically, they have shown 98% protection after.
Madam, unmute, please.
Unmute, Kara.
Okay, so they have shown, these trials have shown a good efficacy, but as of today, the ACVIP has recommended, it is basically for programmatic work by WHO. So not for us in our private clinic.
Okay. So you have a situation, Dr. Sharmila, 13-year-old girl receives first dose of HPV, now comes at 16 years for the next dose. So now, how many doses you are going to give her? 2 doses or 1 dose?
So this child actually, she has received the first dose as 13 years. And I have just said below 14 years, there are 2 doses. So even if she comes later, she receives only 1 more dose. So this child will receive 2 doses.
Okay, okay. Now you have another situation, 10-year-old female received first dose on the 10th October. When it is the earliest that she can receive the second dose.
Right. So here she is 10 years old. So first thing is that she will receive only 2 doses. The second is when will she receive at the earliest? So normal duration would be 6 months, but the earliest that you can give a vaccine to any child is at 5 months. So here, if you count, it comes to about 10th of March. So the gap should be minimum of 5 months, if not 6 months.
Okay. So the point is well taken. The gap between the first and the last dose minimum should be 5 months. And if at all, it would have been a 3-dose schedule. So what will be the minimum gap between the first and the second dose?
So if it is a 3-dose schedule, the gap between the first 2 doses ideally is 2 months, but you can minimize make by 1 month. And between the second and the third, it will be at least 3 months. But here we have to remember that totally we cannot give all 3 vaccines over a period of 4 months. The ultimate gap has to be 5 months.
5 months.
So you can
postpone
it
the
once.
Gap between the first and the last has to be 5 months.
5 months. Absolutely.
So a 9-year-old girl gets first dose of HPV4. Can she take second dose of HPV9 if at all you are giving her a choice?
She is 9 years old. She needs 2 doses. She has taken 1 dose of HPV4. She can very well take the second dose with HPV9 because it also contains the same serotypes and some added.
Okay. Now you have another situation. She has taken 2 doses of 12-year-old girl, received 2 doses of HPV4. And after 6 months, she had come to you at the age of 16 years. She wants to she had read somewhere on the Google or something, and she wants to take the HPV9. Is there any data of any improved advantage of giving a third dose to her with HPV9?
Yeah, so this is a very common scenario, especially in the metro cities. Now with HPV9 coming in and all the ads, people are asking this, but there is absolutely no recommendation of revaccination. This child has completed the vaccination. So she should not take.
There is no indication for giving third dose in this particular situation. Okay.
No.
Thank you. Thank you. You were very crisp, Dr. Sharmila.
Thank you.
Now coming to Ganesh, we are not left with too much time, Dr. Ganesh. I would like your quick responses from your side. So influenza vaccine, now you have a recommendation for uniform dosing, whatever may be the age of the child. So any data of the effectiveness of influenza vaccine in India so far?
Absolutely, there is no such data of effectiveness in India per se, but it is said to be very moderately low effective.
So, if at all you want to comment about the strain mismatch in India, is there any data?
No. There is no such data as far as possible right now of strain mismatch. But perhaps that is the reason why effectiveness is so less in Indian scenario, because there is a potential of mismatch always happening between circulating strains and the vaccine strains.
Okay, so there is no data. So you can always mismatch it. Okay, no problem.
Yeah.
So
and about the uniform dosing, I said.
Yes.
Uniform dosing, initially we used to give below 3 years 0.25 ml and above 3 years used to give 0.5 ml. But it was a story which came up that the whole virion vaccine was very, reactogenic. And to reduce that reactogenicity, they tried to give the half dose of whole virion vaccine. And then they found that it was almost equally efficacious. And similarly, they tried it with split virion and subunit. And then they found that the half dose is also equally effective. That's the reason why now it is a 0.5 ml for every one of them.
So the dosage is universal, 0.5
universal
ml,
now, 0.5 ml
of the dose. So you have an immunocompetent healthy child more than 5 years of age. Would you consider giving influenza vaccine to this child?
Actually, the disease burden is much higher. In Indian scenario, if you consider, disease burden is much higher below 2 years actually. But up to 5 years, the total number of acute respiratory infections, almost 10 to 20% are because of influenza. But up to 5 years, the disease burden is still much higher. Above 5 years, it is not so documented in Indian scenario. And then second thing is, that's the reason why it is not recommended above 5 years. It is below 5 years, it is recommended by Indian scenario.
So you have to identify certain high risk group, and then only you can recommend.
Then only you are supposed to give it,
okay.
not for
okay.
all. Not
now
for
we
all.
are in the southern hemisphere as per the WHO, and why we are using northern hemisphere strain? Quick comment only.
India is a different story. It is basically, we have a different seasonality in the same country itself. So that is the reason why we have peaks happening throughout the year. And the extreme north has a northern hemisphere like seasonality. So we have mix of seasonality. That is the reason, like, the recommendation is whatever the recent available strain that you have to give it.
So the take home from Ganesh is a very big answer. That is, whatever recent strain is available to you in your office practice, please give that strain only. Don't consider the north and the south at all. Okay. Then is egg allergy, is it a contraindication or a precaution for giving influenza vaccine?
It was contraindication before, but now it is converted to precaution. So lightly eating eggs without having any reaction, you can safely give it. Somebody has eaten egg and had some kind of heaves happening, you give it to him, but keep him for under observation for 30 minutes. If someone has eaten egg and had severe reaction last time, you have to be cautious. Still give him the vaccine, but under, in a hospital setup where you can resuscitate this child very well.
So you have a 4-year-old child received 1 dose of influenza at 6 months of age. Comes to you now for vaccination. How many doses you will give? 1 dose or 2 doses?
2 dosages. If he has received only 1 vaccine before, he has to take 2 more dosages.
Okay. That should be the important take home. Now, 4-year child has received 1 dose of influenza at 6 months of age and a second dose at 2 years of age. Comes to you now for vaccination. So 1 dose or 2 doses?
Now here 1 dose. If any time in life he has received 2 dosages, whatever interval between the two, he has to take only 1 dose here.
Okay, thank you. Now, the most important burden of influenza with lot of morbidity and mortality is below 6 months, where we are not giving the active immunization. So can you address this situation by giving the vaccination in the antenatal period to the mother, so she can have the protection for herself and also for the coming baby? So what is your
most of the times we understand that giving vaccines in pregnancy is contraindicated. Live, we do not give it at all. In case of killed also, we are a bit cautious when we want to give a vaccine to a mother who's pregnant. On saying that, now there are only 2 vaccines which we recommend. In fact, we want our mothers when they are pregnant to get these vaccines. One is Tdap and other is influenza. Now there is a wonderful study, mother gift study from Bangladesh, which has found out that there is absolutely no adverse effect of giving influenza vaccine in pregnancy. On top of it, they have found that it definitely helps in 3 ways. One is like, it prevents influenza to the mother for next 6 months, postpartum 6 months. In fact, it prevents influenza to the infant which is about to be born for next 6 months. And third is it reduces definitely the hospitalizations in the infant for next 6 months. So this is a triple advantage.
So absolutely, this is a very important take home from Dr. Ganesh, that you should always sensitize your OBGY friends that they should start practicing giving influenza vaccine irrespective of the trimester. It is safe in first trimester also. Okay. Now, few quick comments about MMR vaccine from Ganesh. There is some anti-vaccine lobby which is always there across the globe. It is there in US, in India.
This saga went on for years together, and in fact, this was something which derailed vaccination coverage at that point of time. This was Wakefield who wrote a paper in a Lancet, which was again then retrieved. 2001, there was a systematic review which said that there is absolutely no causal relationship between MMR and autism and GBS and any other SSPE-like things. So this is taken out. It is absolutely ridiculous.
Now, you have a situation, very common situation nowadays, Dr. Ganesh. You have a 2-year-old parent comes to you for vaccine against mumps because one of his friend has suffered mumps in the last week. How do you proceed? He had received 1 dose of MR in the National Immunization Program.
Yeah, now this is happening in recent times. This has been happening very commonly because there was an outbreak of mumps which was happening, and then people realized that they have taken MR only, and that's the reason why the child is suffering from mumps right now. So most of those patients who have received 1 dose of MR in the NIP have started coming to a private practitioner and asking for mumps vaccine now. Now, if we have to protect these babies against mumps, we will have to give 2 dosages of mumps vaccine, MMR vaccine thereafter with a gap of 4 weeks.
Okay. And after the last dose of MR vaccine, which he has received in the NIP.
Yes.
Okay. The second dose of MMR we can give at 4 to 6 years also. Okay.
Yes.
And there is nothing like post-exposure prophylaxis in the mumps vaccine, if at all I am not wrong. MMR is not
problem is with, see, in MMR, post-exposure prophylaxis holds true for only measles. It does not hold true for mumps and rubella.
Oh. Yes. So I think we have heard enough of MR vaccine. We will skip this. In an outbreak situation, can measles vaccine be administered below 6 months of age?
See, here is a situation when above 6 months you can give in times when there is an outbreak. But below 6 months, there is going to be a problem because CDC says that below 6 months, there's going to be a interference between maternal antibodies, which, along with the MMR vaccine. And then second drawback is, if you still give this MMR vaccine below 6 months of age, it is going to have a hampered immunogenicity and which will not be covered up by future MMR vaccines thereafter. So below 6 months, it is still, you should not give it.
So any new development in measles vaccine?
No, I do not know about it.
Okay. Now coming to some rapid fire. Satish, are we left with some time or we have to wind up?
We got 15 minutes more.
15 minutes. Okay, I will try to be as rapid as possible. Sir, anything Nitin Shah sir wants to add to the discussion till now?
Sir isn't there.
Acha. Sharmila, 6 months old vaccinated child with BCG, no scar. Would you repeat BCG?
Yes, give it for 1 dose.
Okay, nice. Typhoid vaccine, 1 dose or 2 doses?
1 dose.
There is no advantage of second dose.
There are many studies.
Many studies. Okay. How late can the first and the last dose of rotavirus vaccine can be given?
So
Always a confusing thing.
Yeah. So we should stick to what we have been taught. 14.6 weeks is the first dose and 8 months is the last dose.
And specific indication for Shingrix, the zoster vaccine?
Only in people above 50 years immunocompromised.
Okay, nice. Now, 10-year-old is going to Gorakhpur with his father because he wants to campaign for Rabies. When should he complete the JE vaccine before travel?
2 weeks.
2 weeks before. Okay.
This is rapid fire, so I'm trying to answer in 1 word.
So the nation and the MAHA-IP wants to know, Sharmila, how soon after chemotherapy we can start vaccination?
So it's 6 months, but the inactivated flu vaccine should be given annually, and we should give vaccination to the contacts.
Okay, nice. So can Prevnar and Menectra can be given on the same day?
No, it cannot be in Ersplania. We have to have a 4 weeks gap and first Prevnar, then Menectra. But that's not the case with Menectra. Yeah.
Child vomits after giving rotavirus vaccine. I think bloody, this is a situation of hard block to the pediatrician.
Here, Ganesh will be able to convince the parents very easily, but no, the answer is there's no need to. You should be able to convince the parents.
Convince the parents. So, Ganesh, you have a situation, the last one to Dr. Sharmila. 32 weeks preterm, 1.4 kg, received IV IG 400 mg per kg dose. When to give BCG, OPV and hepatitis B?
And as soon as the baby is stable, even before discharge, we can think of it. And definitely no to waiting till the child becomes 2 kgs. In
Okay,
fact, there is
okay.
a government this thing that it is a crime not to give hepatitis B at birth. Huh?
Okay, okay. So Ganesh will skip this because these are theoretical things.
I know. This is very
We'll come to is it consent is mandatory for vaccination?
Up till now, no, because it is an implied consent. But
Okay.
the new process is coming up now to take a consent.
So this is a very common situation in our day-to-day practice. A child has received inadvertently given MMR intramuscularly and hepatitis B subcutaneously. So does the route of administration is crucial for some vaccines?
Yes, of course. See, now here MMR given IM doesn't matter because there is something which is called as the vaccines route of administration crucial are basically all inactivated vaccines. Route of administration is very crucial. Suppose if you give hepatitis B subcutaneously, you have to repeat it because the killed vaccines have a limited antigens. The number of antigens is limited. You cannot reduce the number of antigens. That's the reason why you cannot change the route. So all killed vaccines route is crucial. All live vaccines route is not crucial because they keep on replicating in the body.
So very important take home, all the inactivated vaccine, the route is very crucial. If the proper route is not followed, that dose is invalid, but not so for the live vaccine. That is the message.
Most important is hepatitis B and rabies vaccines. These
Yes,
two,
yes,
if you
yes.
give glutately, you have to repeat it.
Okay, okay. And now, गणेश, you have a situation. तुझ्याकडे एक पेशंट आला सकाळी त्यांनी MMR वॅक्सिन घेतला 14 month old बेबी. नाव त्याला असं वाटलं की यार आपल्याला व्हेरिसेला वॅक्सिन पण त्याच दिवशी घ्यायचा आहे, तर तो संध्याकाळी तुझ्या ओपीडीत आला. आणि सो वुड यू लाईक टू गिव्ह व्हेरिसेला ऑन द सेम डे to this child?
See, there is always, this is a debatable issue because we say that all live vaccines, you give n number of antigens on one particular day. If you have to give live vaccines, you can give multiple live vaccines on one particular day. Now, one particular day means what? Whether it is 12 hours, 24 hours, but by far, what is recognized is it is one clinic time. One clinic time means 6 hours.
एक मिनिट येतो. Okay.
So that's
so
one
how many
clinic
time you
time.
record the temperature? How many time you record the temperature?
Twice in a day. Twice in a day.
Okay.
Twice in a day.
Okay. Following natural typhoid fever, there is a need of TCV, and when?
Yes, of course, yes. As early as possible when the child is better.
And what is the how you define
basically it is any untoward medical occurrence after giving a vaccine which doesn't have any causality with the vaccine itself.
Okay.
When do you suspect? If it is very early onset, rapid progression, and if more than two systems are getting involved, like CVS, the mucosa, or then you suspect that this is anaphylaxis.
So that will be a absolute contraindication for the next dose, if at all there is an anaphylaxis. So thanks a lot, my esteemed speakers, both of you. You were really wonderful and you were really on the target. Once again, lot of thanks to the Maha IP team, Dr. Ram Gopal sir, Secretary Dr. Amol, Dr. Satish for being the MOC, and I had to excuse because I had to leave to attend an emergency in my PSU. So So I will request Dr. Satish to wind up. And if at all there are some questions in the chat box, I think both of the eminent speakers can take those questions. Again, a big thank to Dr. Sharmila and Dr. Ganesh. Thank you all.
Thank you so much.
Sir. Thank you, sir. Thank you very much. And it was a wonderful session because almost day-to-day questions what we face in our practice has been taken very well by Dr. Sanju sir. 2-3 questions are there whether we should monitor the temperature in ILR because we got 2-3 types of vaccine storage. One is a
No,
normal
ILR
place.
you do not have to monitor because it comes with a data logger and that gives you entire temperature record for last 1 month. Few of them almost have 1 year's record coming up every minute to minute.
And it has a inbuilt thing which can monitor the lower and the upper temperatures.
Yeah. So it is shown like outside what we have got new 2-door I think fridges are there which can show the internal temperature like latest one. So there is no need to have the internal thermometer.
But we need to look into that data logger. Otherwise, just because data logger is there, that does not solve the problem.
Yeah, that's true. But at least morning you need 2 times you need to check.
2 times we need to find it out whether it is working well.
Yes. One more question was there for Dr. Sagar. We have explained about 1 dose of flu vaccine at 6 months, and then after 2 years the child can give only 1 dose or 2 doses.
He's received only 1 dose prior.
Yes.
And then he comes again, so he'll need 2 doses.
2 doses. So it's any child 1 dose is invalid. So you have to take the 2 doses when you are taking as a complete dose. Then afterwards, in the life, he can take single dose.
Yeah.
Okay. One more was for Dr. Sharmila for that. He has taken 1 dose of HPV4 at same. I think he's repeated like Dr. Whether he's taken the second dose as HPV9, whether it is single dose or it requires 2 doses.
It will be a single dose because if first dose is taken before 14 years, there will be only totally 2 doses. So it will be a single dose.
2 doses.
See, if you are trying to complete the series, you need only 1 dose of HPV9. But if you want to give benefit of those extended serotypes, then you will have to complete the series of HPV9.
But if she has taken 2 doses of quadrivalent, then there is no recommendation from ACVIP because you cannot restart the series again. So
No,
as of today,
questionable, but
not recommending.
Recommendation wise, no. But then on one-on-one basis, you can start giving them.
Okay, and sometimes we get adults like maybe males around 35-40 years now coming for the vaccination for Gardasil 9 because still it is valid in the US. It is not valid in our country. So whether we can give it.
So it is not, at the moment, it is not valid in our country. At the moment, we can only give boys till 26 years of age the vaccine and not beyond that. So Sarvavac we can give till 26 years and the nanovalent vaccine we can give till 14 years.
14 years.
Yeah.
See, this is in vaccinology, this is called as off-label use. If something which is permitted and it is under CDC, but it is not in recommendation of your own country and you still want to give it, it is an off-label use.
Yeah.
You can like take the consent from parents and then
Yeah.
Okay.
It has been given in the other countries.
Yes. Because many patients who's been there in the US and all, they come back, but then they don't take there because of maybe cost or something like that.
Yeah.
They ask here to like get the vaccine. And the flu, sir, you have mentioned about the 5 years cutoff for flu for normal population.
Yes.
So
thereafter, it is only reserved for high-risk cases, not for all.
Not for all. So there is no change in the like what we used to have.
Up to 5 years, it is uniform, universal recommendation.
Flu vaccination. Okay. I think Ram sir, they have covered each and every question.
Sometimes the parents come and ask. So if the child is 4-year-old, the mother says, you give me the influenza vaccine.
Yeah.
So if they insist, as Ganesh said, off-label, you can give the parents, especially in the COVID times, a lot of adults.
Yeah, that was true.
Vaccine.
This time when everybody was taking that.
Yeah.
Dr. Ganesh Kulkarni, you said that the consent is not required for the vaccination. But I think in the most of the countries, they if I go medico-legally, it is, though it is not compulsory, but it is better that we take a consent. because sometimes these vaccines have got a complication, and any complication due to vaccine, it goes up to assembly and local municipal authorities. So better to take the consent that you have explained all the side effects, and the parents are giving the consent to take the vaccine. So I would say better to take the, though it is not mandatory, but it is always better to take a consent.
Is ideal, I think.
Yeah.
So many charts were there initially. They had that written down one statement saying that so complications can happen. We are all informed of that. Take one shot of that sign there for the parents, and then finish it off.
Don't
that.
take sign on
Pre-written.
pre-printed form.
Yes, that is not
It is
accepted.
not valid.
Okay.
It has
You
to
have to
be
write.
a handwritten consent from the parents.
Okay, from the parents.
Yes.
Yeah.
So the people, whatever is there.
Pre-printed consent should not be taken. I am repeating my word loudly.
So that is in any case or only in the vaccine?
In any case, even in the surgical, what they are taking signature are wrong. It should not be.
Because each and every surgical hospital has their own, like, I would say,
What,
kind
when
of
what
forms
we,
available.
Yes,
Anesthesia
no
form,
problem.
the
It is okay.
language which the parents understand. Pre-printed are English. If the parents doesn't know, वो बोला मेरे को लाके दिया, मैंने sign कर दिया. What proof you have got कि you have explained? नहीं है. So better to explain, take in their own handwriting, and take their signature. That is the most valid consent.
Yeah.
Yes, sir. I think all questions have been taken very well, and the experts were very crisp and clear in the thoughts. That is like given a boost for the our practice now. To, I would say, nobody will, because as sir said, most common AFI is not the because of the products or something, that it is because of the man-made mistakes. So that we can avoid. And definitely about one thing I'd like to ask, because one question was also there, because we used to change the needles to fill the syringe and then change the needle for the injection. So that is not been mentioned in the ACOIP. So Ganesh,
No, it is not necessary. If you want, you need not change the needle. If you prick the vial and then you remove it and give it, it is accepted that you need not change
because in
the
the
needle.
safe injection practices, they are mentioned to change the needle.
No, in our ACVIP recommendation, you can once on one go. If you have already injected by mistake something, the half the dose comes out, you withdraw the needle, then you can't use it again.
Okay.
But otherwise, one needle is accepted.
Okay, ma'am. And I think anybody has any question, you can just open up and then otherwise we'll stop here.
I think
Anybody
there
has
is
any
one question on consent again. If
Uh-huh.
consent written, printed.
Thank you, Ram Gopal sir.
Yeah.
consent written, printed, or local Hindi, that already sir has mentioned. You can take both languages, better to have, and then you just
It
write
is
down
always best to have a handwritten
handwritten
consent
in their own understandable language.
in their own handwriting.
Handwriting. Okay. So medical legal department has become more stringent. So thank you very much, Sarmila ma'am, Ganesh Kulkarni sir, and this duo was wonderful today, explaining all the, I think, flow of sailing the boat of the vaccination dialogue.
एक मिनट हाँ पल्लवी मैडम जरा रिकॉर्डिंग बंद करा.
Thank you, Ram Gopal sir. Thank you so much.
Thank
you so
in
much.
fact, on the flyer, I wanted to give the title "Coffee with Kulkarnis."
Coffee with Dr. Kulkarni.
नहीं, पर actually, मैम अगर आप नई मुंबई में आते तो पेक के साथ ही हो जाता है.
अरे रिकॉर्डिंग बंद होने दो.
हम एक बार कर लेंगे वैसा.
Okay. So thank you, Ram Gopal sir. Thank you, Kulkarni ma'am,
Thank you.
Kulkarni
Good
sir,
night,
and
everyone.
all the office
No, but
bearers.
it was a wonderful session, madam.
Yes, sir.
Thank you so much.
I think we need to take one more part 2 also, because few vaccines are remaining. So better to
Yes, sir.
I know.
take a part 2.
Yeah, it was 45 minutes, so therefore we took only 4 vaccines.
Only 5 vaccines.
Yeah,
No, we will take part 2.
definitely, anytime.
Yeah.
We can come there. You also told Nitin that we will be giving a party.
Definitely. See, madam, all the Maha-AP programs are abhi to even in the today vacation with the people are on holiday, still the attendance reached to 280.
That is wonderful.
It is nice.
And otherwise, during the season, it is almost 350.
350, 400.
We had a highest attendance of 460.
Oh, wow. That's nice.
So
That's
सबको
really
अभी
nice.
so
I think
Nasik
all congratulations to you.
yes,
No,
yes,
madam,
definitely.
it's a team effort. I think that was in women's wing. So even Dr. Manjusa Serekar madam had done lot of efforts in that.
Yes,
Manjusha
yes.
has taken too much.
450. Yeah.
Manjusha,
Great.
congrats to you.
Yes, thank you. Great, Sharmila, Ganesh. It was wonderful.
Thank you.
We learned a lot. Always we learned a lot in vaccination.
Definitely.
Enjoyed. Very nice. Thank you.
तो किसी को भी मुंबई आना है तो ठाना होके आना पड़ेगा वहां से. So you have to take the party and come there. Okay, sir.
Yes.
Thank you very much. Bye.
Okay.
Good night.
Anyway.
Good night, everybody. Thank you so much.
Thank you, sir. Thank you, Ram sir. Thank you.
Yeah.
Thank you, sir.
Good night.
Satish. Okay, bye.
Thank you. Bye. Good night.
Good night, sir.
सर करू मीटिंग